Welcome to my YouTube channel. Today we are going to talk about tuberculosis. So, what etiology of tuberculosis? Tuberculosis is caused by microbacterium, and we have two species: Microbacteria tuberculosis, which is the most common, and mode of transmission is through aerosol droplets. Disease, it causes all form of diseases. Next is Microbacteria bovis. We get it from ingestion of contaminated cow milk, and it gives us TB, GI TB, that is abdominal TB. So Mycobacterium, to be specific, it's a facultative intracellular organism. Gram stain does not strain because of the mycolic acid, so it has specific stain that we use so that you can identify it. That is the Zenhale stain. That is it is stained pink, and then rhodamine reddish yellow when it is positive. So for the culture, we culture it through this Lowenstein Jason media. This is just common microbiology. I hope you remember. So, sites of TB disease: TB can be pulmonary TB, that is 85% of most common cases of TB, or extrapulmonary TB, where it goes to other areas such as larynx, lymph node, brain, spine, causing post TB, TB meningitis, kidney, bones, and joints. We can also have miliary TB, which occurs when tuberculosis disseminates into blood, and it's called miliary because of the miliate appearance in an X-ray, and also pathological. So we're going to talk later in another video more about extrapulmonary TB and miliary TB. As for now, we are talking more about pulmonary TB. So this is a very, very good diagram in explaining to us what really happens after someone becomes infected with TB. So when someone gets infected with TB, they have three fates. So the first fate is either the infection will be cleared by the immune system completely, or the infection will be controlled by the immune system, or the patient, now the immune cannot contain the infection, and they have active pulmonary TB. So I want us to go one by one. Let's start with the first one. So I got infected, and then after getting infected, the infection was cleared. The second one, I got infected. My immune system could not clear the infection. However, it controlled the infection. We're going to talk more about how it controls the infection. Now, this is called latent tuberculosis infection, or TB infection. Now, it will stay in my system, or later, for example, if later it can be reactivated, and now you get secondary TB. This reactivation of the virus, this reactivation of tuberculosis occurs especially when the patient is immunocompromised, or the patient is immunocompromised in terms of HIV, or they're taking some drugs, or they are young. Or you can also have a reinfection, and then later you now have the normal cause of TB. So this is secondary infection. Or where 10% of the individuals will just be infected and go directly to active pulmonary TB. When active pulmonary TB develops, now later they go now into extrapulmonary after the disease is disseminated. I hope you have really understood these three phases of TB. They're very important for you to understand in this lecture. So latent TB, as you have said, also called, the newer term currently it's called TB infection. It occurs when the person breathes in bacteria. It reaches the hair sacs or the alveoli of the lung, and the immune system keeps the bacilli contained under control. This person is not infection and has no symptoms. So TB infection, the newer term for latent TB, the patient is asymptomatic phase, and there's evidence of a cell-mediated response when you do a TST or an IGRA. So TB, in case of TB disease, it starts replicating inside the macrophages, and then primary infection occurs. The cell-mediated immunity gets activated and then surrounds the cell to form granuloma, which leads to the necrosis of the tissue at the infection site, that is the gone focus, which leads to the necrosis of the tissue at the infection site, forming a gone focus complex. If lymph nodes are involved, now you form a cone complex, and this cone complex could calcify, which could be identified in a chest X-ray. So we say tuberculosis is the new term for active disease. Is the new term for active disease. This patient has the infection and presents with signs and symptoms. So difference between latent TB and TB disease. So the first one, both of them, there's tuberculosis bacilli in the body, and both TST and the quantification, that is the IGRA, are usually positive. On a chest X-ray, in latent TB, it is usually normal. In TB disease, it's usually abnormal. When you do smears and cultures, in latent TB, it's usually negative because the disease is contained. However, if you do for TB disease is surely positive. As you have said before, in latent TB there is no symptoms, whereas in TB there is symptoms such as cough, fever, weight loss, among others. And then in latent TB the patient is not infectious, while in TB the patient is often infectious before treatment. In latent TB this is not a case of TB, while in TB disease this is a case of TB. So what are the risk factors that will predispose one to get this infection or to get just infected by TB? So one is close contact to a person with infected TB, people who are skin test converters, recent immigrants from TB endemic areas, children who are less than 5 years with a positive TST, residents and employees with a high risk congregate situation, places which are crowded, such as homeless shelters, healthcare, prisons, among others. Now, when this person gets this person gets infection, or for example, they are in latent, who among these patients are at a higher risk to progress to TB disease? So these are persons likely to progress from latent TB to TB disease include HIV-infected person, people with a who are TST positive with a prior history of untreated TB, underweight or malnourished, obviously the immune system is compromised there, IV injection drug use, people who are or immunosuppressive drugs such as TNF, alpha antagonists, which are they have been treated for rheumatic arthritis, among other diseases, and certain medical conditions. As you all know, when your person is diseased, the immune system is compromised. So infectious, as we said, even before we read this slide and we know what this slide contains, a patient is only infectious when they have TB disease, but when they have latent TB, they're not infectious. So patients should be considered infectious if they are undergoing cough. So now the patients we have had a patient, they have TB disease. They should be considered infectious if they are undergoing cough-inducing procedures, if they have sputum smears positive for acid fast bacilli, and they are not receiving treatment, just started treatment, or poor clinical bacterial response to treatment. In addition to, they have cavitation disease, which you'll see in an X-ray. Extrapulmonary TB, however, is not infectious. Patients are not considered infectious if they have met this criteria. So, for example, they have started their treatment 2 to 3 weeks. As you're going to see in treatment, there's clinical improvement around 2 to 3 weeks after starting of anti-TBs. Favorable clinical response to treatment, and 3 consecutive negative sputum smears results from sputum collected on different days. So evaluation of a patient with TB. So you have met a patient and you're suspecting that this patient has TB. The first thing you have to take is a very good history. Next is a physical examination, and then now you do the sensitivity test, that is the tuberculin skin test or IGRA, in addition to a chest X-ray and bacterial exam where you'll do smear and culture. So this is just all involves clinical suspicion, approach, and definitive diagnosis. So the signs and symptoms. So in systemic, patient will complain of low-grade fever, weight loss, anorexia, malaise, and weakness. In pulmonary, or they'll present with cough, hemoptysis, shortness of breath, and prolactic chest pain. On examination, TB normally presents with a picture just almost the same with pneumonia in terms of consolidation. So on percussion, it will be done, and you will have crackles on auscultation. In cavitation, in case where there's cavitation, it could be hyperresonant on percussion. Where you have bronchial obstruction in terms of lymphadenopathy, which is part of TB, you could have bronchi. Pleural effusion, which is caused by TB, you could have dullness on percussion and diminished breath sounds. So these are just a picture or a diagram showing more about what we are talking about. You have night sweats, low-grade fever, decreased appetite, weight loss. In pulmonary dyspnea or exhaustion, cough, which could be associated with hemoptysis, prolactic chest pain, and pleural effusion. So I have skipped the TST and the IGRA. I have a video on that which you could actually watch it. Very wonderful for you even to understand. In addition to, I have another video explaining more about latent TB on itself. So after now you've taken the medical examination, you have done clinical examination, and your IGRA or TST is positive, you do a chest X-ray. However, an abnormal chest X-ray by itself cannot confirm the diagnosis of TB, but it can be used in conjunction with other diagnostics indications to support TB. So what will you see in terms of chest X-ray? What will you be looking for? You'll be looking for cavity formation, pneumonia-like pictures you have said before, which will be more of consolidations and patchiness, atypical lesions, which are mostly HIV-associated miliary TB, which I'm going to make a video separate from this one, which will have numerous small nodular lesions that resemble millet seeds. You also have a dense pulmonary nodules in hilar and upper lobes, which could be indicative of healed or latent TB, and pulmonary lesions in the upper lobe, especially the apical and the posterior segments of the right upper lobe, which will be indicative of reactivation of TB. Currently note, as you have said, a normal chest X-ray does not rule out TB, and abnormal chest X-ray by itself cannot confirm the diagnosis of TB, but used in other conjunction of other diagnoses, you can now rule in TB. So just review, so cavitation of the TB lesions, as you can see here, and then bilar hyaluronopathy, you can see here, both most common in primary pulmonary TB. So this is a very good diagram showing the features that you will see. So number one, you can see the first one you can see is granuloma, that is gone focus, and then here you have lymphadenopathy I've shown you before, and then this is just homogeneous consolidation. In reactivation of TB, where you can see number 3, we have fibroproliferative disease. Number 4, you have cavities. Number 5, this is looks like white, as you know, like if you check an X-ray of bone, you'll see white. So this calcification, and then we have patchy consolidation. So sputum collection. So in our ladder, we had medical history, we had a physical examination, we had the sensitivity test, that is TST and IGRA, and then we had a chest X-ray, and the next were bacteriological examination. So let's talk more about sputum collection. So you collect sputum, obviously, before you initiate treatment. Sputum should be sent for the following: number 1, acid-fast bacilli and microbacterial culture. So the collection of the sputum, you have to collect 3 sputums, should be collected at least 8 hours apart, and it should include one first morning. In addition to that, you have to do a culture-based drug susceptibility test, and in addition to NNA test with molecular detection for drug resistance. And one of the sputum should be preferably the first in the morning. So let's talk more about culture. So culture is the gold standard, actually gold standard for confirming TB. Culture of specimen, even if the smear is negative, initial drug isolate should be used to determine susceptibility, and then the timing is usually 2 to 6 weeks. A negative acid-fast bacilli smear on microscope does not rule out TB. You just do culture. Culture will be the gold standard. When you're going to talk more about it, or just other tests, when we talk about extrapulmonary TB, where sometimes you can do biopsy in bone marrow. When you see a patient who presents with sense of meningitis, head stiffness, among others, headache, you do an LP. You can do CT and MRI in terms of brain involvement, or you have post-disease, that's the TB of the spine, urinalysis, and urine culture if the patient has GUT complaints. So drug susceptibility testing. So this one, you have 2 methods you have to do. You can do the standard culture, or you do the rapid molecular testing, as you have said, in the NAT, with patients who are at a higher risk of resistant TB. So these are the patients where you just need the results immediately for you to make your decision. So these are patients who have a issue of TB, and now they have TB. Patients who have come in contact with the resistant TB, multi-resistant drug TB, and patients who are HIV positive. So what are the different diagnoses of pulmonary TB? You could have pneumonia, lung abscesses, cancer, interstitial lung disease, sarcoidosis, Hodgkin lymphoma, histoplasmosis. So before we begin treatment, you have to evaluate this patient. The first thing you have to do, just do clinical assessments, nutritional assessment, among all these. But to be specific, you also have to do an eye exam, that is visual acuity. You do visual acuity, color, and discrimination. This is because adapitor, which is one of the 4 drugs that you are going to use, causes optic neuritis. So that when this patient develops these symptoms, you have a baseline to work with. The next is microbial and drug susceptibility, which is very important. And we are saying you can do it with a normal culture, or you do the NNA. The next is imaging. Before you start treatment, you have to do a chest X-ray, which will help you in decisions when you are doing the continuation phase. So do you have cavities in your chest X-ray, among others. In addition, you have to do a LFT, that liver function test, the drug that you are going to use, and hepatotoxins. platelet count, rifampicin causes thrombocytopenia, creatinine, HIV, among others. So treatment for latent TB infection, as I've said before, there's a whole video I've made about latent TB infection. You can just go through that video. However, we have shorter regimens and rifampicin-based treatments I prefer, where you have 4R, that is daily rifampicin for 4 months, or 3HP, where you have weekly isoniazid plus weekly rifampicin for 3 months, or 3HR, where you have daily isoniazid plus daily rifampicin for 3 months. Or you can take the longer regimen, that is daily isoniazid for 9 months. So these are just treatment, but however, you have to follow your guidelines at your specific country or specific hospital. But these are just recommended treatments. So monitoring of these drugs, we have isoniazid and rifampicin. Both of these drugs are hepatotoxic. However, note that isoniazid has higher risk of hepatitis compared to rifampicin. So rifampicin is associated with rash and thrombocytopenia, as I mentioned, which is normally immune mediated. And then for you to discontinue this drug because of hepatitis, it is when the patient is symptomatic and they have serum transaminases of greater, that is ALT and ST, of greater than 3 times upper limits, or they are asymptomatic with ST and ALT elevated to 5 times the upper limit. So treatment of this TB disease. So when you read several articles, you'll see that we have the standard. Most just have a standard, that is the right, that is rifampin, isoniazid, parazinamide, and ethambutol. These are the first line drugs. However, there's one document that mentions that you can use a shorter rifampicin moxifloxacin 4-month regimen. However, let's just talk more about this traditional one. So here you have the intensive phase of 2 months and continuation phase of 4 months. So consideration during the intensive phase. During the intensive phase, you have to treat. You just don't give the patient that's come to the hospital, they have TB, and then you just give them the drugs. As I said before, you have to do pre-treatment evaluation. You have to check this patient as an individual. So, for example, in patients who have gout, patients who have pregnancy, patients who have hepatotoxicity before, then you must exclude parazinamide. So, if parazinamide must be excluded in the intensive phase due to hepatotoxicity, gout, and pregnancy, then you just go with the rest of the drugs. Isoniazid, rifampicin, and ethambutol will be administered for 2 months, and then you continue the continuation phase for 7 months. Now you'll have a total duration of 9 months. So I've said before, as we are beginning, I said the expected clinical improvement or clinical course of this treatment, that you will see clinical improvements of signs and symptoms within 2 to 3 weeks of starting appropriate treatment. And lack of improvement will prompt further evaluation. So how do you assess that the patient has finished intensive phase? Obviously, you do clinical assessments. Do you have your symptom? Are your symptoms still there? You do a smear and you do culture. If the culture is positive, you have obvious, you have to do drug susceptibility testing to determine, is this drug resistant TB? So considerations during the continuation phase. Now, how long will this continuation phase of yours be? So you'll have to, these are the 2 things that really help you, that is sputum acid smear, and for at least 2 months, and presence of cavitation disease. That's why we said in the pre-treatment evaluation, you need to have a chest X-ray at the time of treatment, before treatment. So let's go through these slides. There are a whole, but we shall dissect them slowly. So the first one, sputum should be obtained for acid fast-based smear and culture at least monthly until 2 consecutive cultures are negative. I hope we have understood. So you obtain monthly until the 2 consecutive cultures are negative. A positive sputum culture at 2 weeks. So there's something called sputum conversion, sputum culture conversion. Sputum culture conversion, with a patient, you have now a patient, and then this patient, when you culture, you get positive. The culture is positive. The conversion from positive to negative should have occurred between at 2 months. So when you do a positive sputum culture at 2 months, and it's positive, then you have to suspect, so is this disease that I'm treating, is it drug susceptibility testing? Then you do, and then if you get it is drug resistant TB, you treat the drug resistant TB. So patients with both delayed sputum conversion, that they have not yet converted from positive to negative, the cultures, beyond 2 months, and cavitation at the initial chest X-ray, then the continuation phase will have to be 7 months. And now you'll go a total of 9 months. So patients with either delayed sputum conversion beyond 2 months or cavitation at the chest X-ray, either, so one, or you can either have delayed sputum conversion or you had chest X-ray, then the continuation phase will just be normal, that is the 4 months. Patients with positive sputum after patients with positive sputum after 3 months of anti-TB treatment, further investigation including drug stability testing, and you review cases of treatment failure. These are the times you ask yourself, is this patient taking medication? Is this medication failing, or do we have a drug resistance TB? So because these sputums have stayed for long, that is 3 months. For patients with a positive sputum culture for greater than or after 4 months of anti-TB, then you just presume this is treatment failure. So when to shorten, I would really not advocate for this if the patient is okay. No, so this just this statement says if your patient is okay with no HIV infection or no evidence of TB infection or TB or negative sputum culture, then you can shorten. However, do not shorten. Just do your 6 weeks. That is 2 weeks. 6 months. 2 weeks. 2 months of intensive phase and 4 months of continuation phase. So treatment completion, not this. So completion of treatment is determined by the duration of treatment, and the last statement is a very important statement, and the total number of doses administered. So drug-induced hepatotoxicity. So in drug-induced hepatotoxicity, I said before that the drugs that we give, except ethambutol, have a risk of hepatotoxicity, and the highest risk of hepatotoxicity is pyrazinamide, followed by isoniazid and then rifampin. So hepatitis attributed to TB should be promptly discontinued if you have serum bilirubin of greater than 3, or you have, just as previously mentioned, the serum transaminases are more than 5 times upper limit in asymptomatic patients. However, when a patient has symptoms of hepatitis, then the serum transaminases, that is STLT, are more than 3 times the upper limit, you discontinue. Then once these factors, that is the STLT and bilirubin, have returned to the baseline or fall to less than twice normal, then you can now return or restart now you can now restart the anti-TBs again. So when you are introducing the anti-TBs, you start with the list. You start with rifampin and then isoniazid and then later pyrazinamide, checking if the patient can really tolerate the drugs. So these are just side effects of the drugs that are the first line drugs. Isoniazid causes vitamin B6 deficiency, where you have peripheral neuropathy. It can also cause CNS toxicity, which will cause decrease the threshold of seizures which are not refractory to treatment by benzodiazepines. I hope you have understood. So it will cause seizures. Even when you give the drugs for seizures, the seizures will not improve. This is because the problem is usually the pyridoxine, which is inhibited by isoniazid, and is very important in synthesis of GABA. So the next is pyrazinamide. Pyrazinamide, as mentioned before, it causes high hepatotoxicity in addition to hyperuricemia. As you have seen in the previous slide, that you can discontinue the drug if the patient has gout. So it decreases excretion of uric acid. The next is ethambutol, which causes optic neuritis. We have mentioned before. This is reversible red-green color blindness, and rifampin, which is orange discoloration and thrombocytopenia, as you have mentioned before. This is immune mediated. However, not isoniazid and rifampin. They interfere with the cytochrome P450, meaning that they interfere with other drugs, metabolism of other drugs. So treatment of monoresistant TB. Treatment of monoresistant TB, this is where you have resistance of one of the drugs that we are using in TB. So we have the first line. We already said we have isoniazid, we have rifampicin, we have pyrazinamide, and ethambutol. So isoniazid monoresistant, you have the following options. So the option 1, you just do daily rifampin and ethambutol pyrazinamide, and you replace with 1 fluoroquinolone, that will be levofloxacin or moxifloxacin, for 6 months or 4 months after culture conversion. I hope you all by now understand what is culture conversion. Option 2, if the patient does not tolerate pyrazinamide, Then you just do the following regimen. Just remove parazinamide from your list that you do rifampin, ethambutol, and fluoroquinolone for 9 to 12 months may be used. So rifampin resistant is monoresistance is just kind of treated as multi-drug resistant TB. The reason behind this is because this is rare and it's usually a surrogate for multi-resistant TB. The next drug is parazinamide. Patient with parazinamide monoresistance just do isoniazid and rifampin for 9 months. And then many isolates with parazinamides monoresistance reflect Mycobacterium bovis disease, which we said causes GI tuberculosis. So treatment of polyresistance. So this here is where you have resistance to more than one anti-TB drugs. However, should not be both isoniazid and rifampin. And do not forget that we said rifampin or resistance we treat like multi-drug resistance. So this refers to TB. Isolate of Mycobacterium tuberculosis that is resistant to more than one anti-TB agent. The isolate may be resistant to either isoniazid or rifampin and not both. So when your patient is patient with TB resistance to isoniazid and ethambutol, you remove the drugs and you add a fluoroquinolone, which you say with levofloxacin or moxifloxacin. So you do rifampin, parazinamide, or one of the fluoroquinolones for 6 to 9 months. If your patient has isoniazid and parazinamide, then what do? Just remove the isoniazid and parazinamide and you treat with rifampin and ethambutol and just one of the fluoroquinolone for 9 to 12 months. If your patient is resistant to isoniazid and ethambutol and parazinamide, the three of them, then you treat your patient with rifampin, fluoroquinolone, one of the respiratory that is levofloxacin and also moxifloxacin, and one or two of the additional oral agents, second line agents, that is could be either linezolid, clofazimine, or badiquilin for 9 to 12 months. So next is treatment of multi-drug resistance among the rest of drug resistant TBs. So here we have two options where you have abbreviated regimen that is which is good for 6 to 12 months, or a longer individualized treatment, which is all oral medication at least for 18 months. So in this abbreviated regimen, you could have there are two of them. The preferred one is the first one, that is bedaquiline, protamide, and linezolid. The first one we said we do them 6 to 12 months, or you do bedaquiline, protamide, linezolid, and moxifloxacin. You just add moxifloxacin and you administer them orally for 6 months. In an alternative where you don't have bedaquiline regimens, which are usually preferred for multi-drug resistant TB, then you can do delamide, linezolid, levofloxacin, and parazinamide for 9 months is also acceptable. Thank you.